We can speak very briefly about vaginal, well, since this is in this order, maybe we'll touch on mycoplasma. So I guess a few things to say about women, and it's not necessarily vaginal discharge. So when people are having routine pap smears, that is an opportunity to discuss opportunistic sexually transmitted infectious diseases testing, but it is not compulsory to take swabs in women when you're doing a pap smear. Because, remember, old women who are happily married like me, I'm refusing actually to have any more pap smears, but that's a different topic of conversation. But old happily married women like me, if I had a chlamydia test and it's a PCR test and it's positive, my pre-test probability is low. And so actually that is more likely to be a false positive than a true positive, not because the test is crap, but because the pre-test probability was poor, unless people know things about either me or my husband that I don't know. And so it causes a lot of trouble, and again, unintended consequences. So, and a lot of trouble, you know? So somewhere along the line, it has snuck into clinical practice to do chlamydia and gonorrhea testing and a normal bacterial swab at the time of pap smear. No, no, no. If you're doing a pap smear on a 25-year-old young woman who hasn't settled down with one person, yes, then that's when it's appropriate to have a conversation about STI screening. But even in that setting, if there's no discharge, then they don't need a bacterial swab. So it's just the chlamydia and gono testing there. So most women can do self-collects, and I think the whole thing about the cervix is a bit more tricky now. So if someone presents with vaginal discharge, I'm not sure that they do always need to have a biomanual or a cervical inspection. So if it's someone who has thrush and you have a look on the outside and it's red and it's angry and there's white yucky stuff, then I think that's enough of an examination. And I don't think the cervix needs, and we don't need, because we've moved to PCR or NAT testing for gono, the cervix is nowhere near as important in the micro lab as it used to be. And I guess the other thing, and we're going to talk about PID is a clinical diagnosis. So doing a swab of the cervix does not necessarily help you with what's causing the PID further up in between that little tubey thing. So taking a cervical swab nowadays is more unusual than not. Self-collect swabs. And then know your local epidemiology. So people like to do everything, but and you might think, so chlamydia is the most common STI, and gonorrhea is actually not common, but we test gonorrhea on everyone who we get a specimen, because the way the manufacturers make the kits, they add them in together, and it's much more cost effective for us to do it all together. But overall, among people having STI testing in Auckland, gonorrhea sits at about 1%, where overall people having that sort of testing in Auckland, chlamydia sits at about 6 to 7%. And then in terms of, when I say know your epidemiology, Trichomonas vaginalis is not part of we've got molecular tests for that now in many labs, not all labs across the country, but it is not in that sort of 2 target, and to add it on is to double the price, and so we can't do Trichomonas testing for everyone. And we know from a study that we did that Trichomonas is mainly seen among Māori and Pacific and people who have lower socioeconomic addresses, basically. That's how the data gets collected. So again, it's not appropriate to ask for trich testing in your white middle-class woman who looks like she's got thrush. She looks like she's got thrush. Treat her for thrush, you know, and it's only down the line. If symptoms continue and your first time you haven't worked out, or you know the tests are negative or the thrush treatment hasn't worked, only then, because we're getting into the habits of this whole syndromic management, but it can end up with expensive testing and also with testing where if your pre-test probability is low, like my preference would be not to have gono as part of the chlamydia thing for that reason, that gono, outside of, again, unfortunately, Māori and Pacific, gono is actually not common in New Zealand. Post-menopausal vaginal discharge, and it'd be interesting to hear what you do, Bruce. I've got a girlfriend who is a GP. She says, I just put them on some estrogen cream and it goes away. She said they can come in with a really quite unpleasant discharge, put them on estrogen cream, it goes away. Some GPs and nurses are sending us in swabs. We grow all sorts of E. coli and and Pseudomonas, and then everyone gets stressed. Should we report it? Should we treat it? You know, people have been given ciprofloxacin for that. Actually, try some topical estrogen cream before sending a swab.
I don't know if my gem has come out on vaginal self-swabbing, but this was from an evidence-based primary care unit in Edmonton, and actually self-swabbing is better than actually going for the cervix. And their thought was, you've just got a bigger surface area. You know, if you're trying to get a cervical sample, you might miss, but just a vaginal sample, well, you're going to hit things. So actually, ironically, so I think of, you know, unless a patient's got obviously lower, you know, you think they've got PID and you want to do an exam for that, there probably is. And certainly in the schools, there's no way we'd be doing pelvic, A, because of resources, and B, because I don't think the kids would submit to it.
No.
Good,
So,
well done.
That's vaginal discharge. We'll just see if this goes on to talk about Mycoplasma genitalium. Have we got another swab? Or
Sorry.
This is just a little bit again cribbed from Min. I don't know why GPs and prescribing nurses are not allowed to treat thrush properly in the community without finding a clinical microbiologist for permission to use fluconazole. I think it's absolutely ridiculous. I think if men got vaginal thrush, then fluconazole would be available in the supermarket. Now, I'm not normally one of these anti-male type people, but in this particular issue, it is ludicrous to me. So women who've had 4 episodes a year of thrush, or 2 episodes in 6 months, or anyone who seems like they're having a miserable time, fluconazole 150 milligrams stat, repeat in 3 days, repeat in another 3 days, and then once a week for 6 months. You do have to get specialist approval, but I have got GPs in Auckland where I say if it's a female who's not otherwise unwell, not taking lots of other medicines, then where there might be, you know, just a normal female, got problems, you can use my name. If they get breakthrough on that, then, so we don't do sensitivity testing unless we get a swab in, we grow candida, and the clinical details are breakthrough on regular fluconazole, because that's the only time when we really see resistance. So if you've got a concern about, so when you stop the 6 months, about half the people will relapse. And that's not resistance, it's just because you've taken away the fluconazole, unfortunately. Because some women have problems with thrush, other women don't. And then there are other topical measures they talk about, which is mainly using lots and lots of lubrication with sex and avoiding harsh soaps with washing in the vaginal area. But no need to treat partners, no need to do liver tests with the fluconazole unless there's a specific concern. And then some patients just end up going on it for longer. Sometimes it's they've got a new relationship and they're having more sex, and so that sort of precipitates it. So it's a huge, huge problem. I don't know if you see it being a male doctor. No, well, there's a you know, I get a phone call once a week from a GP asking for the, So massive problem. Resistance does occur, and it's not resistance, it's replacement by different candida species that are not as sensitive. Then things start getting awkward and you have to send the patient to the sexual health clinics. If you're in a more peripheral centre and you feel that you're not sure if there is good sexual health people locally that you can talk to, the microbiologists or the Auckland sexual health people actually are very generous with their time. I've always found emails and that sort of thing. So that's that. I don't know if you want to add anything to that.
Just just a side issue. I've seen fluconazole recommended for fungal infections like in nails. Does it fluconazole have action against?
Yeah.
Yeah, because it's not commonly used.
No.
I guess you couldn't use it here because you can't prescribe it for long enough.
Well, I guess it's because itraconazole is got all those dumb absorption problems, and it's got more drug interactions. So actually, if we do still say itraconazole for yeasts and nails, but actually I think fluconazole is probably just as good.
Well, the other thing with the yeast and The other thing with itraconazole, you have to remember to stop the statin in older people.
Yes.
There was a famous case of a doctor on a ventilator in Christchurch who had a rhabdomyolysis and was dying on this ventilator, and somebody came along and looked at his medications on a statin and itraconazole, and they stopped one or the other, and it all turned around. So literally, otherwise you're getting a massive dose of statin, which the higher the dose, the more risk of rhabdomyolysis you've got. It's a very rare side effect, but it's just something to remember. It's a pain in the neck if you want to give a itraconazole to an older person. I sometimes, rather than have to get permission from the lab for younger people, I just get, I just write it and get them to pay for it, because it's only about $15, and it's not a lot. It's pretty cheap. And I say,
Yeah, or you could just write our names in. The other thing is that
I wouldn't do that.
Is calcium channel antagonists in older people and itraconazole, it can precipitate heart failure.
Ooh.
I remember a case at Auckland Hospital, so that's another thing.
Yeah, it's one of those drugs you have to think, it's like Tegretol. Just think side effects when you give itraconazole, and cross-check, the drug to the itraconazole to the drug, just in case.
So I think BV's a nightmare, having never personally experienced it, but recurrence is common, and it sounds pretty horrible for the patients. We do only treat symptomatic BV. There's some controversy around asymptomatic BV in pregnancy, but with the women who have it symptomatically, they do have a lot of problems. I think after treatment, sort of up to 30% relapse. And I think part of the problem is that the drugs that we use kill not only the BV organisms, but they kill the good bacteria, the good lactobacilli. So there's oral options. You're supposed to use metronidazole, but if the patient can't tolerate metronidazole, you can ask for, you have to ask for special authority for clindamycin, 300 BD for 7 days. Now, overseas there are, there is, I didn't realise this until recently, but there actually is the vaginal metronidazole, but it's not funded, but Min says it's about $40 for a 5-day treatment course, and vaginal is better than systemic for this issue, or clindamycin. It's not available, but Min has got some friendly pharmacists in Auckland who will make it up. So I guess again the patient's ending up paying for that, but that will take I don't know, there must be an aqueous base of something, and then they'll make it up and be a proper old-fashioned pharmacist and mix it all up. But obviously it's much nicer to have it topically rather than systemically, because they're both antibiotics that cause diarrhea, thrush, and also obviously you're not allowed to drink when you're taking metronidazole. So and then I don't know if there's another slide on this or not, but there's, so for patients that really struggle, it is thought that maybe these organisms form a biofilm in the vaginal wall, and so you can't ever get rid of those annoying organisms. So the sexual health people use boric acid, which I think is some kind of rat killer or something, isn't it? It's something it's dangerous. Like per oral, it's poisonous, but it's some.
In your eyes, it's not good.
Yeah, but they get this boric acid but it actually works, and that's what they also use for very multi-resistant Candida thrush. So. Or they also do maintenance therapy with metronidazole gel, and then they will. So the sexual health physicians do have extra added, extra for experts. But if I was sort of having a phone consultation with a GP, I would be saying at this point needs to go to sexual health. I'm not confident sort of talking someone through. Yeah, but I think for women it can be quite a horrible. It brings you down sort of a condition. So that's BV.
Okay. Trichomonas?
Oh, we've talked about trichomonas. Relatively specific epidemiology. Know your epidemiology, but as I say, mildly Pacific, people low socioeconomic status, unfortunately. So we can move on from that. PID. I think with PID, you know, I was looking at the New Zealand sexual health guidelines, and they annoy me because I think they're actually too over-inclusive. They want testing for everything. The Australian sexual health guidelines, I think, are easier to read, and they're for people who are doing sexual health work, and they're quite nice, and they seem to be a little bit more pragmatic. And they just say swab. So our sexual health guidelines say to do a vaginal swab for BV, where the Australian ones say just look for chlamydia and gono, basically, because you treat empirically. So your empiric treatment will cover BV and is aimed at covering the STIs. So as a clinical diagnosis, isn't it, Bruce?
Yeah, there's no gold standard. I think even if you put a laparoscope in, unless you get a ovarian abscess, then it's a bit like sinusitis, isn't it? You know, there's a horrendous end, which is clearly bacterial, and then there's this whole spectrum of symptoms where you've got really no idea. And I guess you might, if you get a chlamydia and they've got lower abdominal pain, well then you assume it's PID, but you still never know. No.
So, but it's lower abdominal pain, presenting rather reasonably acutely, mild fevers sometimes, and tenderness on bimanual.
And rule out the ectopic.
So, I think you do chlamydia and gono swabs if the patient in front of you has got that demographic that perhaps more at risk of trach. You might do that, but also again the empiric therapy will cover trach. So, and then you treat empirically, and I think you wouldn't treat the partner unless the swabs came back positive. That's my and the treatment options, they're a little bit, it depends if it's severe. I mean, if they're clinically unwell, then they go into the hospital, but in the community it is the IM, the 500 milligrams IM of ceftriaxone, because that's needed for the gono, and that will also cover streps that might be down there. Metronidazole, which will cover anaerobes, stray anaerobes, and the trach, and doxy for chlamydia, and for MGen-ish, not really though. So I think that's PID.
Okay. Epididymitis.
Is there anything particularly new we need to say here?
No, I guess younger men, it's probably sexually transmitted. Older men, it's probably gram-neggies.
Yeah, and so MSM, G-neg-Bs. So men who have sex with men, they may be more, they may have chlamydia and gonorrhea, but also gram-negative bacilli from the per anal exposure. And Shigella, they get more Shigella, but not there, just normal Shigella. So it's just something to be aware of.
Okay, urethitis and others?
Oh yeah, urethritis. Well, I guess so urethritis, the big ones are chlamydia and gono, but non-gonococcal urethritis used to be chlamydia until we had good tests for chlamydia, and now it's non-gonococcal, non-chlamydia urethritis, so that's still called NGU. That's where we think about Mycoplasma genitalium, as well as some viruses. Now, Mycoplasma genitalium is a big, bad, annoying thing. So Mycoplasma and ureaplasmas are these kind of bacteria that don't have a cell wall, and so they're hard to grow, and we don't see them in a gram stain. And they cause infection, but they also can be found in normal people, and people that don't have any evidence of pathology. And so that's sort of always difficult to ascertain exactly what causes infection. So, but increasingly the evidence is that Mycoplasma genitalium is chlamydia light. So it's thought that if you test a whole bunch of sexually active adults and you test them for chlamydia and you test them for Mycoplasma genitalium, about say if you get 10% of your adults with chlamydia, then about 6% will have MGN. That's kind of how common it is in the community compared with chlamydia. And we've seen that in local data, and that's been shown overseas. And then MGN is thought to be associated with similar clinical syndromes to chlamydia, but not quite as bad. So it's MGN, it's CT light. So it's thought that it can cause cervicitis, it can cause urethitis, it probably is involved with PID, it may be involved with infertility. But the big problem with Mycoplasma genitalium, so the problem is we can now test for it reasonably well on a molecular test, but the problem is the treatment, because only 30% of cases will respond to doxycycline. Only half the cases will respond to azithromycin, and azithromycin used to be about 80% of cases would respond to azithromycin, but has developed resistance very quickly in New Zealand and Australia, and it's in countries where there's been a lot of azithromycin used for chlamydia. So we went from using doxy for chlamydia to azithromycin because it was a one dose, but it meant that our sexually active population's been highly azithromycin exposed. This other organism that's sort of probably moving along in similar circles, similar nightclubs, is heavily exposed to the azithromycin and has become resistant. And so, of those people that are symptomatic, have a positive Mycoplasma genitalium test, they can get treated with azithromycin. It's a slightly longer course than for chlamydia. Half of them won't do very well, and then the only other drug is moxifloxacin, which is not available in the community, but now it's available under special authority, so GPs can get it for this condition once they fulfill certain criteria. And now we're seeing resistance to moxifloxacin. So Mycoplasma genitalium is a real problem. A real problem.
You just specifically asked for it on the...
Yes, and we look at the referrals, we look at the, reject requests. So the current policy in New Zealand, we worked out with sexual health physicians, is that it's done on people who have got urethritis, that is testing is all negative, and they've had a trial of doxycycline, and their symptoms are still there, then they can have testing for MGN. So you, pregnant women? No, well, only if they fulfill those, well, okay. But you wouldn't be giving pregnant women doxy, you might give them, pregnant women, I think with unexplained ongoing urethritis, you might end up sending to a sexual health physician. It's quite, yeah, it's a jolly difficult area. But I went to a conference last year and someone made the comment that if a role between MGN and infertility is established, it will, then the proverbial will hit the fan, because that's actually where people really care about, because so much money goes into, and resource and anxiety goes into managing infertility, usually in older women. So it's a problem area.
Just got a couple. It'd be interesting. You may wish to check the pathways against your because the pathways. Now the other thing, this is a situation I'm sure everyone's come across, is you have a man or a woman come in. They've got a positive chlamydia test. Both parties swear they have not been unfaithful. What is the natural history? I mean, I always fudge it in those situations. If nobody's owning up, I sort of, well, we actually don't sort of quite understand the Do we know the natural history of chlamydia?
Yeah,
could have been from the previous partner.
Yeah, so there was some quite good papers that came out, and you know how sometimes they have those supplementary journal things, and there was some papers about the natural history of chlamydia, and I had a look at the time, but it was about 10 years ago, so I can't really remember in detail. But if both people have got if both people in the partnership are positive, I would say that someone's playing away. But it is interesting. I found some papers that indicated that it may be that chlamydia could have a latent, because chlamydia is an intracellular organism, that it may have there's a possibility that it could have a latent phase. Because, you know, all these things, mainly except for HIV and herpes, everything else goes away eventually, doesn't it? So I think from memory, that chlamydia's natural history is it sort of usually goes away in months kind of thing. But these papers suggested that at least in some people, there could be a sort of a latent intracellular phase, and then at a later date, if you were exposed to, in the paper it was things like penicillin that doesn't really work that well for chlamydia, but maybe changes, makes it feel a bit vulnerable, and so it reactivates, or other STIs like a co-infection with gono, and it reactivates at that time. So I don't think. So I have used that as a bit of a fudge sometimes too, saying, the diagnostic tests that we have now are so much more sensitive than what there was, say, 15 years ago. I can't say that it's not that, someone's had an infection and it wasn't properly treated at the time, and it has an established latency, and then it's recurred, who knows. And I don't know of any active research in that area, but it's quite interesting.
So we just have to keep fudging, I think. Why did you say if both of them have it as opposed to one? I didn't quite get that.
Well, because it would seem like
presumably
it's
they
a
would
decent...
have been passing it back to each other, wouldn't they, eventually, if it was still there.
Because when I'm talking about if it was latency and it was reactivated, it would be a pretty low-level result. Do you know what I mean? So I think I think people unfortunately do naughty things more often than they want to admit to.
UTI. Woohoo.
Oh, UTI. So
there we go.
I think there's a lot of problems here in the world. God put the urethra too close to the bottom in women. Yeah. That would be fun. So, back in the day, BPAC produced a guideline. It was a long time ago now, the 2006 urine guideline. And at that time, they said that if women have a uncomplicated cystitis, they're of childbearing age, do a dipstick. If the dipstick's positive, just give them trimethoprim and away you go.
Yeah, that's what we are doing now. We've got the bundles, and we have a UTI bundle, and that's what we do on a dipstick.
That's pretty much what we do.
Yeah.
Yeah, we don't send it to the lab, we just treat it.
Yeah, I
over 65s, we send them on to the lab.
Yeah, and so that's quite good, and because lab testing at least gets 1,300 urines a day, so that's quite a few. But there's a few problems. So the first problem is the trimethoprim resistance, which is sort of running at 25 to 30% throughout the country. But then we don't actually have data, and we tried to get some data, but it wasn't that we just didn't quite get enough. But we don't actually know if that has a negative clinical outcome for those patients. So you come in, you've got your good going cystitis, you've already started drinking lots of water, you have your dipstick, it's positive, and you get your trimethoprim where you go. It may be that in a portion of these people where the E. coli is trimethoprim resistant, they still get better. So we don't actually know to what extent that laboratory fact is a disaster clinically. We don't really know that. So, but that's the first problem: is should we still be saying that trimethoprim is first line? What have we got in the guidelines?
I think nitrofurantoin may be now in the guidelines.
So
I'll check the BPAC one.
But then the other problem is with nitrofurantoin. Now, I've never taken nitrofurantoin, but GPs and nurses who have. Yeah, it's gross. It's 4 times a day. I think it gives you a tummy upset.
It makes you nauseous.
And it's longer. Yeah. And so the compliance is low. So I don't know if that's necessarily as useful as it looks on paper when you're talking about the real world. More recently, a study has come out from a Scandinavian study where they looked at more patients. They had a slightly lower dose of brufen, and they randomized these women to brufen versus an antibiotic. And the antibiotic people clearly did better, and there was a little bit of pyelonephritis developing in the non-antibiotic people. But what was really interesting is that not all the people in those groups necessarily had a definition of UTI according to the laboratory. And that's sort of what we found when we started trying to collect some urines looking at the trimethoprim issue, is that either the lab doesn't pick up all the organisms that are causing UTI, or we're not as good at clinically diagnosing UTI as we think we are. Because it's sort of, you think, so in the UK now, they're doing consultation around a recommendation that would be for uncomplicated cystitis in women, give them advice about hydration, self-care, symptomatic relief, and give them a back pocket prescription of antibiotics to start if they wished down the path. And I think that that could be quite a good thing. I think, and I think that there are people in our, we have all these rules, but there are people in our society anyway who go, oh, bugger that, I'm not taking it. My GP's given me the antibiotics, I'm not bloody taking them. And so I think that would be a good thing, but it is controversial. Then we get, so that's sort of uncomplicated cystitis. Then I think two other areas of controversy, and I don't know if they're on the slides or not, is asymptomatic bacteriuria in pregnancy, where we're all taught that early in pregnancy, when you have those first antenatal bloods, the women are supposed to have a urine done, whether, just regardless of symptoms, and if it shows bacteriuria, i.e. a significant amount of a urinary pathogen in the urine, they're supposed to be treated. Well, and that's supposed to prevent preterm labour, prevent ascending infection, which can be associated with preterm labour. There's a study that's come out of Holland, the Dutch, that say this is not necessary, and the Dutch don't do this. They do not treat asymptomatic bacteriuria in pregnancy. And I presented to some midwives, about 100 midwives in Auckland, the paper from the Dutch, and I sort of said, oh, what do you guys do? And I said, do any of you guys not treat asymptomatic bacteria in pregnancy? And guess what? Quite a few of them don't treat it.
I wouldn't be surprised. The BPAC thing is nitrofurantoin first choice or trimethoprim. I've had, norfloxacine's an interesting one, so there's a bit of a tendency not to use that here because of, I guess, the flox, trying to keep that class. Yes. But I've had a few older women get quite loopy on norfloxacin. Yes, and so, and also, that's right, so
neuropsychiatric
sort of...
and so Cipro's also got that neuropsychiatric thing coming through. So my colleagues in Wellington here are very anti-Cipro, and they won't release Cipro on urines or Norflox on urines, and because it's got the QT issues with other drugs, it's got the tendons, and it's also now got those neuropsychiatric issues.
And it's not just the Achilles tendon; it's a few other tendons. I think.
So not homeopathy, but
natural.
Actually, I think there is another slide that touches on that. Here, so. So the D-mannose has now been recommended by the British, and that's an adhesion thing. So it stops. So that stops. Now it's a tablet, isn't it? That D-mannose stuff. So
Tiaro by
yes,
Pharma, yeah.
Yes, they've got that. So, but I think, and then they've also got another one.
They've got a couple of things.
Yes, but patients do have to pay for it. But actually, I think there is maybe some funding, not for the D-mannose, but, or maybe does that one, that through those what's it, Tiaro?
Tiaro by Pharma, do you know?
Yeah.
So that's one.
Yeah, I mean, we service a rest home, and we quite often do, I think they're called cran tablets, not cran.
Yeah, but those...
for them, with the D-mannose.
Right.
And you can buy that over the counter.
Yeah.
Purely D-mannose without giving...
Yeah, so the cranberry products in theory don't work.
Yes, yeah.
And then topical estrogen creams for women with recurrent. And I also think some of the conversations I've had with GPs is, so GPs have indicated to me that some of the older women start actually becoming a little bit focused on their urine. And so they'll come in and say, oh, I've got that cystitis back. Do you know what I mean? And I've sort of said, okay, well, how about having a conversation around antibiotic use and resistance and around hydration, which I know is difficult because sometimes elderly people have got other issues and getting up to go to the loo at night and da-da-da-da. But, and also, symptomatic relief and Panadol, and also just a recognition that unfortunately it is what happens when you're old. And we don't actually have, an easy cure for that. Yeah, because there are these women who are having repeated courses of antibiotics. I think that you're probably right that they are always conservative, but I'm nervous about children. I always defer to the paediatricians.
Yes.
So you were talking about the probiotic that you know about for throats.
Plus, yep.
So there's one for urinary tract infections now as well.
Oh, okay.
The
same company. Yes.
Yeah, and so the drug rep was around recently and had stats saying that it's 30% reduced in people that, whether it's worth trying.
I think if people are prepared to pay for it, that's fine, but I wouldn't, and nothing against any particular company, but I think that it's only once you see good clinical trials that have been done by independent researchers that you can, But I'm all about probiotics. I want it to work.
I see you've got long-term antibiotics. So you want to talk about nitrofurantoin?
Yeah, I don't like any long-term antibiotics for urinary prophylaxis because I think it just causes resistance, but then I'm not the person who's having the UTI. But nitrofurantoin can cause those awful lung problems.
Yeah. And did you know there were 20 cases to ACC in the last 10 years of payouts for long-term nitrofurantoin? Jaw-dropping stuff.
What does it do?
It causes an interstitial lung fibrosis in the lungs.
Which is nasty. It does usually improve on stopping the drug, but I don't know if it gets totally better.
No.
Because there'll be fibrosis.
There's just not enough evidence, I think, because there is actually an acute fibrosis. I did a little bit of research on this. So you should stop if the patient starts getting breathless. And the advice is to give a short course of steroids in that situation. Again, there's no trial evidence. But I think the prophylaxis it's effective, but it isn't. I would just stop doing it unless you want to end up with unintended consequences for you. Or you should check their lung function is the other thing. MedSafe have a thing saying check the lung function. I was horrified. I was at the Rotorua GP and Peter Robinson got up and said we had 20 cases in the lung. I said, what? Never heard of it.
Yeah.
It was about 3 years ago. Just be careful, trimethoprim's not as innocuous as you thought. Kids?
I say refer to the Starship guidelines because I think children are complicated. The guidelines are long, but they are available and they do explain to you how they define recurrent. They want Augmentin as their first line, but BPAC has cotrimoxazole as its first line. They point out that if a child's younger than 3 months, they should definitely be in hospital. Younger than 6 months should consider hospitalisation, and obviously severe infection.
UTI nitrofurantoin. Avoid it. Okay, so you avoid trimethoprim in the first trimester, and you avoid nitrofurantoin at delivery time. Men and pregnant women get 7 days of antibiotics for both. So that's asymptomatic bacteria. Are we over-treating? Yeah, it'd be worthwhile doing another study on that, wouldn't it? A big trial, because that goes back to that's 20, 25 years ago.
What I think would be quite fun to do is a retrospective study. So get laboratory data, get ICD-10 discharge codes that relate to the baby, whether they were prem or not, and get PHARMAC data.
Oh, okay.
And do a nice big retrospective data collection. I've got all these plans.